Hello, everybody, and welcome to our webinar. My name is Amanda, and I'm the Regional Critical Care Educator for the area of KHSC. We usually have Rebecca on here, Marcoux for TOH, but she is off teaching today, but she sends her hellos. So I'm very pleased to introduce our guest speakers today from the Regional Stroke Network. We have Kayla and Heather here. They bring extensive experience in stroke care coordination, protocol development, and frontline clinical support across our region. So we're very grateful to have them here to share current best practices and key updates in acute stroke management. So please join me in welcoming Kayla and Heather, and I will hand it off to you guys.
All right, thanks everybody, and thank you, Amanda. I'll start off the session today. So I'm just going to share my screen. Bear with me a moment as I do the steps of switching to presenter mode and swapping my settings and all of that stuff so that hopefully you guys are seeing the correct screen now. Kayla,
Looks good.
Looks good? Okay, perfect. Yeah. All right, so as Amanda said, I'm Heather, and I am the, why is this going to this? Perfect. Okay. My name is Heather Jenkins, and I'm the Regional Education Coordinator with the Stroke Network of Southeastern Ontario. And I'm joined today by my colleague, Kayla Purdon. And Kayla is the Best Practice Coordinator covering hyperacute and acute stroke, as well as prevention with our stroke network. And today we're going to be talking about stroke care. So the objectives for today, I will take the first little bit and we will do a review of anatomy and physiology of the brain and some pathophysiology of stroke, as well as touching on the signs and symptoms of stroke and how they relate to brain anatomy. And then Kayla's going to dive into more about acute stroke protocols and best practices for hyperacute acute treatment, explain the guidelines for caring for transient ischemic attack, and understanding the value of acute stroke unit care. So first, what I'd like to do is just get a sense of who's on the call. And right now, I can't share the screen, or I can't see the chat, sorry, I'm just seeing my own screen. So I'm hoping that Kayla and Amanda, you can just relay back to me. I'm hoping we can take the first three together. So folks can put into the chat where it is that you work, what is your profession, and how long have you been working in healthcare? Just interested to note. So I'll give you a moment.
See some typing.
You see some dots moving.
Yeah. So we have RN clinical scholar, 31 years of acute and critical care.
Anything else popping up?
Not yet, but I see typing.
Okay.
It's coming. 31 years.
Yeah,
Congrats, Steph.
Deep River Hospital ED RN, 4 to 5 years.
Oh,
the Ottawa Hospital neurosurgery RN, working for 2 years.
It's quite a range of experience there. That's neat. Is still more dots, or shall I move along to the next one?
We've got still more typing.
Okay.
RN, Napanee, practicing for 1.5 years. Emergency department. So we've got ED, education, neurosurgery, critical care, Belleville, RN, 35 years.
35 years, fantastic.
RN and clinical educator, specializing neurosciences, 8.5 years. So we've got some neuro experience too.
We do. So I might, that's actually good to note for me, so that maybe the anatomy and physiology I'll go through really a little bit more quickly, since it might be known to some of you, might be a bit more familiar.
Is anyone, or do we have any non-nurses? So far I'm seeing nursing. And it looks like we've got, okay, Deep River, IPAC, Med, Emerge, 21 years. So range of experience, range of areas.
That's great.
And both Champlain and Southeast. The Ottawa Hospital, RN, OR, medicine, now ICU, 22 years.
Okay. Wow, great group, lots of diversity. Thank you. And my last question for the group before I launch into some more content is, how comfortable do you feel providing care for a person with an acute stroke? So if 0 is not comfortable at all, would feel out of my depth, and 10 is, I got this, I feel very comfortable, how would you ballpark your own comfort and skill and confidence?
Got an 8.
Sweet. Like that.
Yeah, and I know for a lot of you, stroke is only a piece of what you do. So
okay, well, keep popping those into the chat. I know it does take some time to come up, but that's fine for that. Thank you for your for sharing that information with us. Okay,
7.
So 7, perfect. Okay, so we've got some folks with some good comfort in stroke. So then some of this should be familiar to you, understanding the incidence and impact of stroke and knowing how devastating it can be when somebody suffers a stroke. So the stats that you're seeing are a little bit old. They don't get collated very often. These are from 2017. There are approximately 109,000 strokes a year in Canada. It's the leading cause of adult disability and the 3rd leading cause of death. But because many people do survive following a stroke, the folks that do so live with a lot of deficit and a lot of challenges. There are close to 900,000 Canadians living with some effect of stroke long-term in their lives. We are seeing that someone has a stroke every 5 minutes, and we're seeing, while the incidence does increase with age, especially past the age 55, we're seeing more and more individuals under that age, 20 and up, very young adults who are also experiencing a stroke, and that number continues to climb, which is alarming. And of course, after you have a stroke, you are at a higher risk of having another stroke, and that stroke risk stays high at up to 25-26% at 5 years, which is higher than baseline. So it is important to understand what stroke is and how it's caused so that we can work on preventing them. So diving into a little bit of anatomy and physiology, a review for some of you, maybe some new stuff for a few. So the brain, of course, is divided into 3 main areas. The area that we all think of when we think of a picture of a brain is those folds and ridges, and that is your cerebrum or your cerebral cortex. And then tucked underneath that at the back is your cerebellum, and then in the middle, leading out into your spinal cord, is your brain stem. And of course, your cerebral cortex is divided into a left and right hemisphere, covering half of the side of your brain, and they are joined in the middle by your corpus callosum. In general, your left side of your brain is going to control functions on the right side of your body and vice versa. So while it is largely duplicated in things like your motor function on your left side is controlled from your right brain and vice versa, there are some differences between the hemispheres, some functions that live only in one side or the other, some areas of specialty. The most notable one is language. Speech and language is in the left, generally in the left hemisphere. Few exceptions with some folks who are left-handed where their hemispheres are actually switched. But for the most part, language being the most notable difference. But the left side of our brain is often responsible for analytic thought, mathematics, science, and those more concrete tasks. Our right hemisphere is much more specialized in the areas of creativity, imagination, music, and art, those sorts of things that are different, but everything else that we have on both sides tends to come from the other side. Make sure I'm not missing anything there. Now, your cerebral cortex is also divided into 4 main sections. So you'll see them color-coded there. We'll get to the cerebellum a little later. That's the purple one at the bottom. But in the red, we have our frontal lobe, yellow, our parietal lobe, blue, our occipital lobe, and green is your temporal lobe. Your frontal lobe is the largest in your brain. It makes up about 60% of your cerebrum. And it is composed of 3 functional areas. You have your prefrontal cortex, which focuses on concentration, abstraction, memory, judgment, insight, emotion, tact, and inhibition. And it helps you sequence your thoughts appropriately and evaluate consequences of actions. And it can help you solve some intellectual functions and guide your behaviors. Notably, we also have an area in your frontal area called Broca's area, which handles expressive language. So how we generate our words, generate the language that we want to use, how our articulation and pronunciation, our voice and our speech. And at the back of it, just adjacent to the yellow parietal lobe, that last bit of red is your motor cortex. And I think we've all likely seen those somatotopic maps where you can see how that's organized coming down from the center of the brain, where there's a leg area, and then the other parts of your body are laid out along that cortex, and those are mirrored on one side or the other. Now, your parietal lobe is responsible for a lot of sensation and integration of your senses. So, and again, that's for the opposite side of the body. It's arranged topographically very similar to that motor strip in your frontal lobe. And it controls how we perceive things like touch, pressure, temperature, how we orient ourselves in space, where our limbs are, where our body is, whether we're vertical or horizontal. That all gets integrated in the parietal lobe. Now, your temporal lobe is devoted mostly to auditory function. So this is how we receive sound and language. So Wernicke's area lives in your temporal lobe, and it helps with comprehension of language. So not just all sound, but specifically language. So if that part of your brain has damage, it makes it very difficult to understand language. This part of your brain also controls your emotions. Your limbic system lives in your temporal lobe, as well as some of your memory. Although memory does have some homes throughout your body, or throughout your brain, sorry. Now, your occipital lobe, I think most of you will be familiar with the fact that this area is primarily related to how we process visual information. It takes in all of the information from our eyes and processes all of that spatial information and that visual information for color, contrast, and visual interpretation. Now, your cerebellum, that darker brown piece tucked under that cerebrum there, also divided into a left and right side, and again with the crossing of the fibers, but it is mostly associated with control, how we control our movements, especially fine movements, as well as balance and equilibrium, and that sensation of rotation all gets interpreted in your cerebellum. Now, your brainstem is a very critical part of your brain anatomy. It has 3 major sections: your midbrain, pons, and medulla. And of course, it is our vital functions. So in your brainstem, this is where your heart rate, your respiratory rate, your blood vessel diameter, hence your blood pressure, lives, as well as your swallowing function is largely coordinated from this part of your brain. It also houses your reticular activating system, so it helps you understand when you're vertical that you need to be more awake. So it deals with that arousal and alertness in your level of consciousness. And your cranial nerves all are generated from your brainstem as well. So moving on to the circulation of your brain, the The brain has high requirements for oxygen and glucose. We need about 20% of our blood every minute. 20% of what comes out of our heart goes to our brain. And it's because our brain is very oxygen and glucose hungry. There's a lot of cells in there to feed, and they are very important, as you can understand. So to ensure that the brain receives blood flow, we have two main arteries on the front and two on the back that carry the blood from our heart up to our brain. So the anterior part of our circulation is our internal carotid arteries, and they supply your brain with about 2/3 of the blood supply that they need. So your brain is taking almost 1 liter of blood every minute, and 2/3 of that is coming through your internal carotid arteries. Your left internal carotid artery branches off directly off of your aorta, and the right side comes off of the innominate artery of the aorta. And before they enter your brain, they also branch off into tympanic and ophthalmic arteries. And after they enter your brain, the internal carotids branch off into what you see in sort of that top portion there. It branches into your anterior cerebral artery, your middle cerebral artery, your posterior communicating artery. So those are the three ones there at the top of your brain that you're seeing, and they take up a large piece of real estate. They supply a large piece of real estate in your brain. Now, your posterior circulation comes from your vertebral arteries. They come up through your spine, and they join to form your basilar artery, and then they branch into your posterior cerebellar arteries as well. Your cerebral circulation is very tightly regulated because your brain demands so much blood and oxygen and glucose. It's very important to maintain that function in good homeostasis. So it's very tightly regulated. However, that regulation is really dependent on the function of the brain. So if there's some brain cells are dead because of ischemic damage, infarction, or edema, we can not only lose the blood flow to the areas that those supply, but we lose some of that ability to regulate the blood flow as well. Okay, so just making sure everybody's awake here. I'll start with, we'll do these one at a time. Pop in the chat there for me, just a quick reminder, which side of the brain is your speech and language center located on? First right answer wins.
I see left.
Perfect. Okay. And what about your brainstem? What does it control? Throw a few words out at me.
Heart rate, respiratory rate, autonomic function.
Yeah, you got it. All those vital functions that keep us alive. Last one, true or false? Your anterior circulation supplies the brainstem and cerebellum.
Not seeing any typing. So
you were on a roll, Brittany.
Maybe she's wanting to give someone else. Oh, okay, she said false.
False, you got it. Thanks, folks. Everybody's still with me? Perfect. Okay, a little bit now into stroke pathophysiology. So, as we said, blood brings the oxygen, nutrients, glucose to your brain, and a stroke is an interruption in that blood flow. Without the oxygen and glucose going to those cells die, and they die fairly quickly. So we know that this can be caused in two main ways. In a stroke, we're seeing that it can either be an ischemic stroke, usually formed by the blockage of an artery, or from a hemorrhagic stroke, where your blood vessels have burst or leaked and are leaking out into the brain. So we call this a vascular disease with neurological consequences. The types of stroke, as I said, are ischemic and hemorrhagic, and for the majority, 80%, give or take, are ischemic, and about 20% are hemorrhagic. Of the ischemic strokes, we have some that are thrombotic, embolic, or they can come from other causes. And I'll get to those in just a moment, and I'll come back to the hemorrhagic afterwards. And your hemorrhagic strokes are largely intracerebral hemorrhages, although a smaller number are subarachnoid hemorrhages, and they are still considered stroke. Okay, so what causes these ischemic stroke? The previous slide just gave you the list. So thrombotic is generally because there's been a progressive narrowing of blood vessels due to atherosclerosis, the laydown of plaque and fatty deposits that eventually cause a narrowing, and the blood can't get through as quickly. When the blood can't get through as quickly, those red cells tend to not be able to move through. And when they get stuck piled up together, they eventually get sticky and they form a clot, and then they block off that artery. Strokes can also be embolic. So this is where a blood clot has formed elsewhere in the body rather than forming right within the brain. It has formed elsewhere in the body. It has broken off and traveled to the brain. Typically, we see most of these are coming from either the heart or the carotid arteries. If they're from the carotid arteries, it's frequently due to damage causing a tear, and the cells are gathering to try and repair that tear, but then pieces break off. Ischemic stroke can have other causes, though it is less common. Only about 10% of ischemic strokes come from other things. There can be an infectious source. We sometimes do see individuals who have cardiac valve infections, and that can leak some vegetation that then travels to the brain. And sometimes we don't know why somebody has had an ischemic stroke, and these are often called ESIS strokes, or embolic stroke of unknown source. Now, this relates to both ischemic and hemorrhagic, but it has more relevance to the ischemic. So when a blood vessel becomes occluded, the cells perfused by that blood vessel die very quickly. And that's generally when symptoms first begin. But the number of cells that have died and are no longer salvageable early on is very small. That's what we call the core infarct. That's not salvageable. However, there's an area of brain tissue surrounding that core infarct that is still okay for a while because it is receiving some collateral blood flow. So those cells haven't died. And if we can restore the blood flow to those brain cells that aren't doing so fantastic, that's what is salvageable, and that's what can reverse the signs and symptoms of a stroke. But we only have a certain amount of time for this to be effective. Those cells aren't receiving enough. So while they may survive for several hours, eventually, if untreated, those cells will go on to die as well. And you can see in this image here, it might be a little bit small. We start out with that small core infarct in the center there with a larger blue, lighter blue area of penumbra. And as time goes on, that core infarct gets bigger and the penumbra gets smaller until eventually it does go on to be a completed stroke. And we've lost our window then to be able to improve that individual situation. So while this applies as well, often in a hemorrhagic stroke, it's going to be that core infarct that first dies. We don't have the same mechanisms to treat hemorrhagic stroke and stop that damage in the same ways that we do with an ischemic stroke, which is unfortunate. So moving on to a hemorrhagic stroke is usually the result of a burst blood vessel within the brain, and most often to arteries that are deep within the brain. The neurological symptoms of a hemorrhagic stroke very similar to the neurological symptoms of an ischemic stroke, but there are some key differences that you see much more often, which is that sudden severe headache, nausea and vomiting. We can see a seizure, reduced level of consciousness. These folks sometimes have uncontrolled high blood pressure, as well as some focal neurological deficits that are related to the location of the stroke. Importantly, these individuals can deteriorate quite quickly. 50% of them will deteriorate within the first 48 hours. And this is because the edema, the cerebral edema that goes along with that initial hemorrhagic stroke. And the major complication that can happen after following an intracerebral hemorrhage is with this increased blood volume, our skull does not have extra space. It can't accommodate a lot of swelling. And so if that were to go untreated, we end up with high intracranial pressure, and the brain can shift one side to the other, or even worse, it can herniate out through foramen magnum, which can be fatal. This generally requires pretty quick intervention. Okay, so you've got the artery in your brain that ruptures in a hemorrhagic stroke, and this creates a collection of blood within the brain. So not only is that blood now leaking out from its source and no longer getting to where it was supposed to get to, but now it's creating pressure. It's leading to compression of the tissues around it, and that's what causes the signs and symptoms. Most often, it's caused by hypertension. But this often goes along with individuals who have cerebral amyloid angiopathy, folks who have a vascular malformation, individuals who are on anticoagulation therapy, and of course, we can have traumatic hemorrhages as well. I touched briefly on the subarachnoid hemorrhage still being considered a stroke. This is slightly different though, because this is when a blood vessel in the brain weakens and bursts, but leads to a collection of blood not within the parenchymal brain tissue, but in the subarachnoid space between the brain and the skull. Again, this collection causes pressure on the brain tissue and cuts off blood supply to the nearby parts of the brain. These are more often caused by aneurysm or vascular malformations in individuals. Unfortunately, intracerebral hemorrhages have a higher mortality rate than ischemic strokes. The mortality rate can be as high as 50%, so 10 to 50% depending on size, location of the bleed. And they do tend to have slower recovery as well, though sometimes can have quite good recovery, again, depending on the size. So with that subarachnoid hemorrhage, before I leave this piece, the symptoms of a subarachnoid hemorrhage don't look quite the same as an intracerebral hemorrhage. They may still have that loss of consciousness, but they could also have double vision, nausea, vomiting, dysarthria, and a sudden severe thunderclap headache. It's often described as the worst headache of their life, and it's very, very sudden onset. Okay, so in terms of what you see with symptoms of stroke, it relates very strongly to the geography of the brain. So where the stroke occurs is going to determine very clearly what kind of symptoms an individual deals with. So if you take it based on the anterior, the circulation, if you look at it by circulation geography, if we look at the middle cerebral artery, one of the main branches that comes off of our anterior circulation, this is the most common artery involved in a stroke. About 2/3 of all ischemic strokes occur in this territory, and it is a large piece of neurological real estate. So this is where you're going to see that hemiplegia, that weakness in face, arm, or leg, the sensory loss. We can see homonymous hemianopsia, which is loss of half of the vision half of the visual field in both eyes, same field. We can see aphasia, confusion or cognitive deficits, emotional lability or control, impulsivity, neglect, and we can see headache. Less common with ischemic stroke, but it does happen. I'm going to jump over to the right side of the screen and look at the anterior cerebral artery, which is really going to mostly your frontal lobe. We can see paralysis, but we tend to see it of the lower leg rather than the whole leg. So we are seeing impaired gait. We have a matching sensory loss. And again, this is where we have folks with that executive dysfunction. They might have a flat affect, lack of initiation, apathy, poor motivation, and continence can be affected here as well. This is less common. We're seeing only 5% or less of our strokes are occurring in the anterior cerebral artery. Just going to scroll down at my own notes, make sure I'm not missing anything. So with the folks who've had an anterior cerebral artery, they might need a lot of help in terms of tasks that they can already physically do. So these are the folks who you can put a toothbrush and toothpaste in front of them, and they have the motor skill, they have the functional ability to do the task, but they can't initiate it. So you need to actually provide that assistance to get them going. Or they may be very flat and apathetic, and they may not have that motivation to do just about anything, and they need a lot of encouragement to participate in daily life as well as therapies. This part of the brain, however, can also see the exact opposite, and we can see individuals who have poor impulse control. So we're seeing individuals who are saying inappropriate things, doing inappropriate things, unsafe things, and we're finding that this is really hard on the family, where they report a lot of personality changes when we get into the anterior cerebral artery. So this can be challenging for individuals. The middle section here, your lacunar strokes, these are the deeper strokes. So they're not happening right at that cortex. They're affecting the small penetrating arteries that provide blood to the deep structures of the brain. These are the individuals that you may see worsen over a few days. The majority of your strokes that are happening in either your MCA or your ACA or even cerebellum, typically when they have their symptom onset, it's sudden and it's as bad as it's going to get right away. If that's sort of a hallmark of stroke. The lacunar strokes are different, and they end up, you just see that they start with certain amount of symptoms, and then they can get worse over those next couple of days. And these make up about 25% of all ischemic strokes. So you do need to be aware that even though most strokes are going to have that sudden severe onset of symptoms, and hopefully they will get better over the next few days, especially with treatment, your lacunar strokes can actually get worse. Their symptoms can continue to develop. Your lacunar strokes tend to have the stroke syndromes. So showing you here on the screen are 5 types. So you might see those pure motor strokes, pure sensory. They could be sensory motor, ataxia-chemipresis, dysarthria, or clumsy hand syndrome are commonly seen lacunar strokes. Clumsy hand syndrome is when somebody has a stroke directly in their hand knob. We have a large piece of our brain dedicated to hand function because of its utility. So we can have a stroke right in the center that affects a person's hand. Okay, so our posterior circulation strokes look a little different. So they're less common, but they tend to